Okay, so thanks for coming. For those of you that don't know me by now, I'm Mike Crosby. I was first diagnosed with prostate cancer in 2015. I think at one point, my friends at one of the big companies told me I held a record. Early on, I had about 5 PSMA precision images. And the key out of that whole lesson or that experience is that I want to say that, and my physicians, oncologists, and radiation oncologists, and everybody will tell you that my treatment changed every time there was an image, because it found new things each time that we had this image done. And so the course of my care, as I tell people, I wouldn't be here had it not been for nuclear medicine, hence why I'm a little bit passionate about this technology. So with that, we would like to first thank all of our sponsors, Eli Lilly, Blue Earth Diagnostics, Curium, Mirion Medical, Eisai, ITM, Lantheus, Novartis, and Telix for your generous support. Without you, we would not be having this event, and we wouldn't be educating these patients that are out there. So we got 2 incredible speakers that have been leaders in this industry. First, to my left here is my friend, but also highly respected physician, Dr. Francis Amigel. He's a nuclear oncologist who serves as the director of the Molecular Imaging and Therapeutics Program at Loma Linda University in Loma Linda, California. He's currently the chair of SNMMI's Prostate Cancer Outreach Working Group. So if you have physicians or offices or clinics that want to hear details about precision imaging and nuclear medicine, we have an outreach working group, which I am privileged enough or honored to be on as well, but we are always looking for opportunities to come and speak at a very technical level about what is nuclear medicine and how it can be applied in a clinical setting. So contact us if you have any or you hear of anybody that wants that. And I think you'll hear through these next few minutes a little bit about Dr. Amigel's passion and how this works and why we're doing all this. So first is, I'm going to ask him to answer this question: what is nuclear medicine, and how is it different from other imaging or treatment options that all of you may be familiar with?
Well, nuclear medicine is unique. Before it was used to be called unclear medicine, but now with the new scans and new advances in technology, we're becoming pretty clear. And imagine that we're looking at the functional aspect of cancer instead of looking at structures like when you do a bone scan or a PET CT scan or an MRI. Structures, now you're looking at moving parts, how the metabolism works inside the cell, so you can tell a lot more, right? It's not the same to show just a brick structure than when you can look inside what's happening inside that bridge. So we can make decisions like my friend Mike was saying. Imagine he was privileged to be doing this even before the approval of PSMA imaging. So I was going to mention later on that, yes, the advantage that we have today is that we have the problem of having advanced imaging to let doctors make better decisions. Sometimes that means more work for doctors and more thinking, but this is actually better for patients. And I tell all my patients, you have to be an advocate and you need to learn about your disease. You have to be not only for you, but for your fellow patients that are going to come and ask you. You need to be an advocate. You need to talk to your doctor. You need to be involved. You need to make a decision together with your doctor. You cannot let your doctor just say, this is what you do. But this is not the question now. So nuclear medicine is a precise field where we are able to give you more information and about the functional component of an imaging.
Great, thank you. So next is molecular imaging in precision oncology. It's biomarker imaging, really, which is going to allow us to see things down at a molecular level.
That was the answer of the question.
Right.
I had it in a picture. So if I show you the CT scan portion of that patient, you will not see anything. But you can see, you don't need to be a radiologist or a medical specialist to see that. And let me ask you this question. Do you see where the cancer is?
Here.
Anybody? Tell me where the cancer, you see the cancer cells, the cancer metastasis. Okay, Mike, press the button.
I did.
Now with the PSMA PET CT, you can see what they are. This is better for patients because it's better for physicians because it gives you more information about what to do next. And this actually was a patient that was scheduled for surgery. And we found that. If we had done surgery, we had given him all the side effects of surgery and no real benefits. We could close the talk right now saying precise imaging allows us to treat patients better. And Dr. Sartor and I are here because we took a note to help our patients, and this is definitely helping us help you, and I'm telling you, it's a great feeling where you're informed, where you can make the right decision for the right patient at the right time with the right tools. Well,
So here's the technical side of the world here. So there's a little bit of a technical deal, but this is down at the molecular level and what you're really looking at. So explain, if you would, how this really works and why it's really working.
So as you know, Mike is a very smart person. He served in many leadership components in this planet, but I gave him a lot of freedom. I gave him some slides and he chose them for me. And sometimes, I'm telling you, this is a very good slide. This is the reason why nuclear medicine is great at looking at function, because we are a biomarker-based imaging and therapy scenario, right? So if your prostate cancer cells has 1,000 times more PSMA than your, toe cells in your toe, then when you image, you're gonna see the prostate cancer cells. You're not gonna see any other cells. And I'm very general because I don't want to go into details because of the specificity of PSMA, but it's overexpressed in prostate cancer and is expressed very little in others. Now, imagine if you want to send a micronuclear bomb to the cancer cell. You want to make sure that it's the collateral damage is little. So that's why we want biomarkers like this. Okay? Mike, I'll follow your lead.
No, it's good. So how is it determined that a patient should actually have this done? Or who determines that? Where does it come up in discussion? What should the patient say, or what should a smart patient say to a physician about this during his visit?
I mean, Mike doesn't know this, but this is a very loaded question. So there are like multiple guidelines and hundreds of hours between very smart people deciding when should we do a test, right? When should we do this? But I can tell you this, and we're going to make this question relevant for you. If you have been diagnosed with prostate, and let's forget about all other cancers, and let's be very, very, very selfish. Let's forget about everything else, just prostate cancer. If you have been diagnosed with prostate cancer, and your PSA is changing, so if you're initially diagnosed and they have done a biopsy and your risk is higher than, at least on 6 or at least on, you say, hey, maybe talk to your physician about this test, because the decision between doing surgery, radiation, or other therapies hangs in the balance of with the right diagnosis. And as Mike mentioned before, a PSMA PET-CT changed the way his case was managed. And just like it changed the treatment scenario for the patient that you just saw the picture with the little bullet in the prostate, right? Yes, you have to be part of, if you don't know anything about PSMA, you should, if you're here today, you have a problem because of having access to more information. You need to know what a PSMA PET-CT is, and you need to know how that could affect your disease. So the idea is PSMA imaging is changing the way we manage prostate cancer.
And so what's coming down the line? What should people be hopeful for? Or this kind of is going to lead, we're kind of going to merge into the trials issues that Dr. Sartor is going to speak about. But I mean, what's happening in the field right now? I mean, this is evolving. Someone said yesterday that we are facing a tsunami of information or a tsunami of data that's going to come out with all of these trials and all the research and development that's going on in nuclear medicine. And you're an expert in a lot of them, right? I mean, you're doing a lot of, just doing 1 or 2 trials, I know right now, right?
Several.
Yeah, 22 trials he's involved in right now.
But I can tell you this, with knowledge comes much responsibility, right? Now that we know how PSMA has not only revolutionized the ways we image, right? And the way we make a diagnosis. Now that we know that it's also very important in a therapeutic intervention, right? We have our PSMA-related therapy treatments, which you're gonna hear more about that soon, but is actually helping our patients live more meaningful lives with less side effects and with a increase in survival. So when you put all that together, you have to answer a question when somebody tells you, hey, what about if I don't have prostate cancer? And this is not only confined within prostate cancer, when we're using more and more isotopes to do the same thing, hopefully better, but this is also spilling away from basically all other cancers. And we don't have time to talk about that, but I can tell you, this works, and we just need to find a way of making it work better.
So there's a concern from everybody in the room's perspective about radiation safety. And, you know, am I going to glow in the dark? I mean, I know I have an incredible personality, but, you know, is this making me glow, or, you know, is it just our friendship?
I think it's a combination. No. So I was in, I remember like today, I was in a room treating one of my most quiet patients. There was this little mice, and I was injecting the tail vein of those mice. I don't know if anybody had done it, but it's complicated. And I was injecting them with a radioactive arsenic. As you know, arsenic is bad, it kills you, right? But in the amount that I needed for doing imaging, these mice were just fine, because this tracer principle in nuclear medicine is I can give you a tiny, and he's actually trying to show you a grain of sand in the hand over there, right? That little touch.
It's not on there.
It's not on there, but basically, I can give you a really tiny little thing that is not going to affect your physiology. So you could be a diabetic, and I'm doing a FDG PET-CT. It's not going to increase your blood sugars, right? So the bottom line is it works in a soft-physiological level, and the radioactive safety, in the radiation safety components, this is a really, really safe, and when you look at risk and benefits, the risk of having a scan is nothing compared to the benefit that it can give you. But even when we say that, we are very careful selecting who gets the scan. We're not gonna just do a scan just because Mike checks in the door, hey, we get a scan. And we do it before. If you do the imaging for the right reason, there should be no concerns with other side effects of this imaging. It's a very safe procedure, and it can have great opportunities to change the outcome of your disease.
So I have a question for you. Why is it when I go in and have my scan that they put you in a lead-lined room and you have these, big rubber gloves that everybody's wearing, and they shut the doors, and, just to bring this little vial, it's only about this big, bring this little vial in there and then inject it into your body? Why are we protecting this thing like it's like what we just bombed in Iran, right? I mean, it's like, you're living in this lead-lined room and getting an injection in your arm, but it's, the lead's what, 3-4 feet thick, and it's like, it's crazy. So why, then you tell me that it's not scary or it's not gonna hurt you. So why do we have these big rooms that we're doing this in?
Well, we have a commitment with society, with our patients, and with the world. Because since we cannot see radiation, we have a commitment to have as low as reasonably achievable. So we're gonna try to minimize the radiation that can be affecting anybody else but the patient. We have worked really hard to make that into a reality. However, we have regulations. We have a thank you, sir. So the bottom line is, yes, we have protocols and we have these procedures to follow, but it's just because we want to make sure that we are very clear that we are doing everything we can to limit radiation to where radiation shouldn't be going to, right?
So are these big walls really for, like, if you spill the stuff on the floor?
No, not really. Actually, we have procedures after you're gone home that we check that there is no spills of there's no radiation just lying there. All this, like. Remember,
so don't be scared of the big lead-lined walls and stuff like that.
Remember, you have CTs, PET CTs, and you have machines, and it's a complex environment. What I need to tell you is you have to be not only thinking about your patient, about your employees, about the visitors, about you. It's basically, since you cannot see the radiation, you want to be sure that if somebody asks you for your policies and procedures, that they can show, hey, we have done everything we can to tell you that we have done all by the book. And that sometimes that book means that you have to have those regulations from everyone, from all the societies, right?
Okay, so we ask, when a patient first hears about this, what are questions that you typically get or that you try to encourage patients to ask and to understand in that first visit when they first hear about that they're going to get a PSMA PET or you're looking at a nuclear medicine precision image or something like that? What are questions that patients really should think about asking the physician?
So patients come to, first they're diagnosed, and this usually happens very early when the primary doctor will see that the PSA has changed. That triggers a reaction where he goes to a specialist and more tests are performed. And then there's some things that will trigger a PSMA PET CT. And very few patients have the opportunity of sitting with their physician to discuss the PET CT, right? Results and look at the pictures. So when you first come to the center where I am going to be performing the PET CT, your referring physician have already told you a little bit about this imaging, I hope, right? And I also encourage my fellows and my patient interacting personnel to ask the patient, hey, if you have any question, I would like to talk to you. I would like to give you an opportunity to know what you're getting into. But basically, it's just going to be injection. We wait for some time to circulate, and then we'll sit you in a machine where you send the energy to translate that radiation to pictures, and then hopefully those pictures will change the way we treat you.
Yeah, for you guys that haven't had one before, I can tell you from experience, you literally show up and you can't be late. The reason you can't be late is they set a time, and all of this nuclear medicine has a half-life, right? I mean, we're talking hours from the time it's manufactured to the time it has to be inside your vein, okay? So if you get stuck in traffic, if you get stuck somewhere, it's gonna be a problem, and you're gonna have to come back and do it again, right? So it's imperative that you get there a little bit early, and believe me, it's worth the wait. So and what happens is they give you an injection, you check in like anything else, they take you in the room, you get an injection, and then you wait. You've gotta go wait for your body to process it, right? It goes up through, what's it, about an hour, I think now, 40 minutes to an hour? And then, at that point, they call you back and you lay on go take a 20-minute nap on the PET CT machine. And what's brilliant about that is when you're finished, the results are right there. That's what I think is neat. I mean, I guess probably because I'm a little bit mouthy and I know Dr. Barangi pretty well. He would take me right into his room and show me exactly what was on the screen, right? And so they're trying now to standardize or to optimize the image reports that people can get as a patient, because you don't, there's a lot of technical stuff in those reports, right?
Absolutely.
And we also try to promote that not everybody is trained to read those reports, okay? So not every physician knows what they're looking at. So you gotta sometimes ask or challenge the guys to make sure that they're qualified to be able to read those reports. Or if you have a question, as we always say, go get a second opinion. Take your report and go get a second opinion, okay? And anybody that has a problem, I mean, I love you to death, but, I may ask a second opinion of Dr. Sartor, and it's one of those things that doctors shouldn't care. If they care, then you're seeing the wrong doctor.
Actually, this is very critical. I believe in my patients becoming experts here, right? So I send my patients to top physicians in America. Say, hey, you go ask him. I mean, I'll be available for you when you're talking to that physician. Just put me on the phone, because I want you to hear it from multiple directions. Because when the patients come to me and they tell me, my urologist told me I needed to do surgery. My radiation oncologist told me I needed to do radiation. And the other doctor was not sure. I am not sure. What should I do? I say, wait, I cannot tell you what to do. I can guide you, and we can make a decision together, because patients that feel comfortable working with their doctors and making a decision together with their doctors, they don't only feel way better about what they have done. There is data that shows that these patients live longer, and I cannot take away that from you. And hopefully they don't, I have some patients that have been fired by their doctors because they asked too many questions. And they want to know about that clinical trial, about these other things. And they'll say, if you're coming to me and you're not doing what I'm saying, and you go somewhere else and talk to other doctors, just go somewhere else. Don't come to me. You don't want that doctor. I'm sorry. And if you're one of the doctors that are a friend of mine that are doing that, I don't know. As a patient, you need to feel comfortable with your doctor, and you need to actually make sure that he's seen it for you, because at the end of the day, you're not a statistic. Statistics are funny because it's 1% to 100% or 10%, but when you're that statistic, you're 100%. I don't know if you understand what I'm trying to say. What I'm trying to say is your wishes should be very important for your doctor.
So we're gonna merge into to Jan and Dr. Sartor's talk a little bit, because I know a couple of these guys that we're gonna look at some pictures of, and these are first it's Theranostics, right? This is where this word comes from. It's essentially merging therapy and diagnostics together and just doing it all at once, right? You got to look and see what you're treating. Is that right?
And that's the beauty of nuclear medicine. You can have a biomarker that can be used to take a picture. You're just changing the biomarker. And then you exchange that isotope from a picture taking to a nuclear bomb. And I remember when I made this little video, it's funny because...
If it'll go. Whoops.
Is it going?
I don't know. Let's see if I can make it go.
Oh, you're going to have to click on it. It's okay. Don't worry about it.
Okay.
But basically, you can send that micronuclear bomb to the actual metastasis. And you could see changes in these patients.
We're going to see a couple.
So this was one patient, very good friend with Mike, that my patients get together and talk and share their pictures, and I will tell you, like a friend of mine was saying, why you don't have more PSMA PET CTs from this guy? It's because his PSA is undetectable, and I don't want to do more PET CTs if he doesn't need it. However, you'll get one when the decision is triggered, but this is his 3 post-therapeutic SPECT CTs. You have a PET CT in the corner, PET CTs in the corners, and the post-treatment scans in the middle between the 3 treatments. The point is, patients respond really well, but not all patients are the same. And when I brought this patient the other day, a couple of years ago, to the society meeting, he went to Novartis and he went to all these sites showing that, yeah, this worked for me. And when you are in a good regimen and you respond well, there is no better feeling for a physician to know that his patients are doing well.
Yeah. When it works, it really works, is the point, right? And so here's another one.
This patient told me that when he saw Mike last April, he made him work like 10 miles in DC, and he was with us going to every single of the offices that we went, pleading that you look at what you do for prostate cancer. We need the research support. We're not there yet. If you pull funding from basic research now, you're gonna see that affecting patients years from now.
We do a Hill Day every year. We go to Capitol Hill, and this year our mission was, with the new administration, was to try to convince Congress to maintain the research dollars that are out there and not cut certain dollars, or if they're going to cut dollars, that we really force them, or we're really strong about telling them, and this is patients, this is you guys, telling the congressman that, listen, if you're going to make cuts and you're going to rearrange money, keep it in these technologies that are making a change and keeping people alive, okay? We're just at the beginning of research, I think, in nuclear medicine and its applications in the world. And it's a crime if we start cutting back on the research at this point. I mean, we should be accelerating research in nuclear medicine right now, not subtracting it, okay?
I was very clear to tell to the offices I had the chance to speak to. I told them, look, prostate cancer is independent. It could happen to Republicans, Democrats, or anyone. So don't vote on anything else. Just put the patients first. And
this is the guy that we walked around with. So that first picture that you saw in there, I mean, he was diagnosed very late stage. I mean, metastasis across his entire body. And in pain, he would tell you that he was feeling the bone pains. And like Dr. Amagel just said, I made him walk 10 miles across Capitol Hill. And, we laughed about it all afternoon and had a cocktail at the end. And that's what this message is all about. It's preserving life and preserving the quality of life. And giving a guy more and more years. I mean, he was facing something that was going to take him out in a matter of months probably. And, through, your skill and skills of other physicians, we're still having a good time.
well,
Where's this headed? Where are we going?
we're going to areas where we have more precise interventions earlier. And
Do you think it'll be targeted by an individual's requirement for treatment?
I hope that we transition from precision medicine to precision health. So how do we find a problem before it is a problem? And I know that Mike is very passionate about early detection and about decisions to change paths and processes, but I will tell you, and being here with very in this very meeting, I will tell you that this is a combination of multiple people with multiple ideas pushing the field forward. I couldn't have done a lot of the things I did for this patient without pillars in the field like Dr. Sartor, right? Dr. Richard Baum, or those people that have changed, that have done things for patients and they have put their lives and their careers to serve others, right?
Okay.
But I'll tell you, we're not done yet. There's still a lot to do. About 600,000 patients die every year of cancer. We are not there. We still need a lot of help. And yes, we need to celebrate our victories with our individual patients at this time. But I can tell you this. We need all your support and we need your intervention with people you know to pass this forward and move this field forward.
So what inspires you? Why are we here? Why are you here?
I'm here because of my patients. There's no one can give me anything that surpasses what I feel when I see one of my patients do good. And the trust that they put in me, I'm actually, I will tell you that being a physician is a great privilege because you're able to give hope. Even when the things are not like we were just going through. There's some things that are thrown at you that are not fair. But at least you know that there's somebody that's going to help you, that's going to be with you through that. And I get really upset when somebody says, the patient failed this therapy. No, the patients don't fail anything. We fail. Our therapies fail. The patients progress on therapies. What I can tell you is today, you and your doctor should work in a journey that journey ends in a relationship that you know that you have somebody that cares for you, and you know that there's somebody that when he doesn't know the answer, he's going to go and find out for you. You're going to consult with his friends to see what can be done for you. And I hope that's what we're trying to do here. And patients and friends like Mike make my life better because I can have my patient call him and talk to him about other things, right? It's always good to have a message from a patient, somebody that has walked the walk, because it's different from me. Even though I've been in those journeys, it's not the same. You need to hear it from your fellow patients, and you need to hear it from people that you know that are committed for you.
Questions?
Mike, yeah, do we have time for questions?
Yeah.
Anybody have a question? Raise your hand and I will bring you the microphone.
Now it's on, yeah. Anybody have any questions that you want to ask Dr. Abigail or myself?
And this talk was about nuclear medicine imaging.
Yes.
I have a question.
Yes,
I know that we're talking about the PSMA PET scan. I know there's right now FDA cleared or approved 3 different kinds, but then there's reference to a SPECT scan. Is that something you use after treatment to monitor treatment because insurance would not pay for a PSMA PET scan unless your PSA was going up? Did I get that right?
In nuclear medicine, we're so privileged that therapy that you're getting, right? That when you switch from the micronuclear bomb to go destroy the cancer cells, that is beta radiation that is killing the cancer cells, but also has gamma radiation that can tell you exactly where the cancer cell, which cancer cell is taking the medication. So you could see where your therapy is, and that's why we use a spexity.
Thank
and
you.
It could be done right after the therapy. So it's not a substitute for a PET-CT, but it's a very good idea for you to know how are you responding.
As a patient, should I ask my doctor about a SPECT scan?
I would,
Okay,
if possible, I want
Yeah.
you to get it, yeah.
yeah. But it happens right after the PSMA PET? Is that what you're saying?
Well,
Or
no, I mean, right after the PSMA radioligand therapy, the therapy.
right after the therapy? That's what I was, right, because at that point, insurance wouldn't pay for a PSMA PET if your PSA is going down.
Yeah, I think.
That's not how the label reads,
Well, you see,
correct?
we can go into the appropriate use criteria, and there is
Okay.
a somewhat appropriate to do a PSMA PET-CT to assess progression or response, right?
Right.
So you can have a PET-CT to see how you're responding. So it's not only for resources, but it's like that is free. It's a free image. You already have the radiation within you after therapy. You have up to a week to do the SPECT. So technically, I will love all my patients that have therapy to have a SPECT.
Okay, I'm just,
It's not easy, but yeah.
want to help patients know the questions to actually ask their doctor in the appointment, to really give it to them with some clarity, because it's hard. The information's overwhelming. So anybody else have a question?
One
I
in the
got
back.
two, hang on.
Yes, sir. Oh, wait. Go ahead, Frank.
Hey, Frank Leskus, Blue Earth Diagnostics. Earlier today, Dr. Aiken talked about radiation exposure to patients, and of course, when we're talking about late-stage disease, I'm not sure it really matters at that phase, but if we're doing a SPECT-CT following each application of Pluvicto plus a PSMA PET in the beginning and maybe a PSMA PET after dose 6, that could be 6, a bunch of different scans. Is that increasing the radiation exposure to patients that we need to be concerned about, or is it, okay?
In the SPECT-CT, especially when I'm just doing a whole body scan, there's no extra radiation for the patient. He already had the radiation. You will lie there, and the machine will pick up the energy. There's no extra radiation to him. And there's a lot of useful information that could be used in the future. I mean, look, you saw the pictures from my patient. We have SPECT-CT after every treatment, and that's not extra radiation for him. It's just he shared his radiation with us. So if I had to give him radiation after, then that would be different. But I think it's a good technology. It also can be used to measure dosimetry that could affect the way that I will do the next treatment in the ideal future. There are trials working on that. So the bottom line is, for a patient with advanced prostate cancer that is undergoing these treatments, information is good.
That's good. Mike?
Yeah, Mike Philbin, I'm a patient. So I've got a question surrounding if men have biochemical recurrence. At what level of PSA or range would you typically start being able to see something on a PSMA PET? At 0.2 nanograms per mil, at 0.5? Where typically might you see that?
That's a question that Dr. Sartor and I get often. We have new powerful scanners, but the rule of thumb is that 0.5, at 0.5, I have a 40% chance of seeing something. Dr. Sartor, can you add to that, please?
No, it's a great question, and it kind of depends on when you ask and where you go. And so the conventional gallium-68 and F-18 imaging, Frank is exactly right. If you're in that kind of 0.2 to 0.5 range, it's only about 40%. But there are new techniques coming, and they're different ligands, different isotopes, copper-64. There's a clinical trial with copper-64 that looks pretty promising.
Oh, yes.
Yeah. And so, and that might change. There's also some interesting hardware, software solutions to this. I spent a little time down with Rod Hicks down in Melbourne, and with some of the newer scanners, which are very restricted in the U.S. today, the sensitivity can be dramatically enhanced. So when we talk about that 0.2 to 0.5 and quote the literature, it's a changing dynamic, and it could be a different answer tomorrow.
Absolutely right.
Thank
That's
you.
why I got, when you have a question that is complicated, you load the boat.
So we have a question from YouTube, I think. I'll come to you, Frank, just a second.
Yes, thank you. A question online that is asking, sorry, scrolled down on me. Oh, they retracted their question, sorry.
They retracted their question.
Yes, message
Okay.
retracted.
We're
so-
friendly. They can ask questions. If we don't know, we'll figure it out together.
So, sorry about that.
Yes,
Any
sir.
other questions? Please wait for the mic so that the people online will be able to hear as well.
Yeah, just a
Thank
second.
you.
Yes, these new technologies or processes where you actually target the very specific cancer cell. You know, with prostate cancer in the days of old when I had my radiation treatment done, basically it killed the prostate. With these new targeting things where they go in and hit the actual cancer cell, will that prostate then be viable, live, whatever you want to call it, after the treatment and the cancer cells are gone?
You know, that's an interesting question because I think today prostate is still the only gland that is treated from a whole gland perspective. Like every other gland in your body with cancer, they take out like a piece of it or a portion of it, right? So we just haven't probably complained long enough yet or loud enough yet. I don't know. Do you think we're going to get to a point where we can actually viably treat portions of a prostate?
I think I might have to phone a friend here. So I'll tell you something. I tell you experience.
Which one do you want?
Put the one where you saw where there is like a ball all the way to the beginning.
Oh,
Keep going. And I'm gonna tell you something there about that.
This one or
the
this
other one, the one. That patient. He was a doctor. I said, look, I just want this dot to be treated. I don't care if you have to come back tomorrow to treat the other one, but you just treat that one. I will tell you, we do things based on evidence, based on clinical trials that we have proven outcomes. I don't know about the future, right? Now we're merging with all this imaging, right? We're doing PSMA guided radiation therapy, external beam radiation therapy. So the future is exciting, but also we have the fear of change. There are many changes coming, right? That we are in a field that today they're going to present things here that we didn't know yesterday, and it might change the way we do things tomorrow. I don't know the answer about this, but the urologists are doing less prostatectomies and more focal therapies. In the future, you might be able to have a focal therapy to your prostate cancer that might, yes, it might leave other areas where cancer can grow and cause problems in the future, but maybe it'll buy you some time without more intervention. But I only tell you that research we will continue to find ways to increase the quality of life of our patients. So as of today, yes, when you have prostate radiation, classic is not really the whole prostate. Now people are saying PSMA radioligand therapy, that you do it when there are patients that have diagnosed, like the patient you saw there with hundreds of metastases. They don't get a prostatectomy or radiation to the active prostate. But I'll tell you, in the future, there'll be other things that we could do. But you have to stay engaged and stay positive because there are great things happening in our field because of advancing technology and because of physicians that are pushing the field forward.
So anything's possible, but it's going to be really difficult if they keep cutting research funding.
yeah, right.
Is that fair?
That's fair. That's
Thank
fair.
you.
I just want
Thank
to be
you.
happy.
So write your congressman. Tell him to keep the funding in line.
Right.
Okay, so we're going to merge now to our next speaker.
Okay. I'm going
Right.
to give this microphone to Mike.
Oh,
And I'm going to come up there.
yeah. Do you want me to read the introduction, or are you going to? So our next physician speaker is Dr. Oliver He's the director of Transformational Prostate Research Center at East Jefferson Hospital. He's also an adjunct professor at Tulane University School of Medicine here in New Orleans. He was a co-principal investigator for what was called the VISION trial, which ultimately led to the approval of some of the first nuclear medicine therapy for prostate cancer. He's also been a mentor to me recently, as I was a patient member of the steering committee for PSMA 4 clinical trial. And I want to encourage industry that's here in the room to please reach out to other patients. It's a bit of a learning curve to start on a clinical trial as a member of a steering committee, but when you have patients or physicians that are investigators that are patient enough to educate us along the way, towards the end of the trial, it's fascinating because I think it's fun to actually make an input to these incredible researchers that get so focused on the research that sometimes they forget maybe how to translate that into patient speak, right? And it's been an incredible experience, and I wanted to say thank you to him publicly because for including me in that multi-year trial, and it's been an education. And I encourage any patients in the room, if you're offered that or you would like to do that, we can try to get you into some of the corporations that are doing the research that we went down to talk to today. And more clinical trials are involving patients on those steering committees. So with that, I'll turn over the dais to you. Yeah, let's go.
That's my phone. I'm good. I just need the clicker.
You need to get, that computer doesn't work. That's mine. Yeah, here. Don't drop it.
Sartor, water, if you want it. You're welcome.
Are you,
I've got the clicker.
I got it. Let's see.
Just want to do a quick microphone check. Can everybody in the room hear us okay? Got a lot of thumbs up. And if you can't hear us on YouTube, just type something in the chat box there. So that's beyond my expertise.
This one doesn't have your brief on it.
Oh,
It's behind
well,
you. Sorry.
On and off.
Your clicker works, though.
my clicker works. There it is. Okay. Oh, so we have to turn to look. We don't have a monitor. That's okay. That works. Okay, Dr. Sartor, you want to check your microphone real quick?
1, 2, 3.
Everybody hear us? We're good. First of all, how are you? Hello. We've known each other years, and you've done great advocacy work with me, and I don't, like Mike said, I don't know much to express how much I appreciate it, so.
That's very kind. I appreciate you, and I hope the patients do, too.
Thank you. So I want to start with my story a little bit because I think it's important. It helps people connect and relate. So my late husband was diagnosed in the year 2000. He was only 58. I was only 45, and our son was only 9. His PSA was 7,096.0, and he had bone metastasis in bilateral pelvis, bilateral ribs, his entire spinal cord, causing spinal cord compression, and his skull. I know it's a lot, so it's okay if it's a little bit shocking. It's all right. He was very stubborn, as you probably figured that out already. I got involved very quickly, and before I knew it, especially because we had a 9-year-old boy, that will get a mother involved like that. Before I knew it, I was reading his medical records, and I used Google as a dictionary to look up those big words. Did you know that osseous just means bone? I don't know why they don't just say that, but that's okay. I found out. And I used those medical records to, process what was going on. Then I used it to develop better questions. Then I found that better questions got me better answers. And about a year and a half into his care, this was way back in the year 2000, before we had most of the treatments we have now. But I found that a year and a half into his care, I actually chose a treatment as an idea. I brought it in as an idea. My husband and I had been talking about it. And I'll never forget that I was right. And his PSA, when we got it down to the lowest point, was 0.022. It's a very long, complicated story, but he lived for 13 years. That's way beyond anything that anyone could have predicted. And any survival statistics you can quote, I would encourage patients and caregivers to not let a static quote of survival statistics stick with you, because most survival statistics, by the time they're published, they're outdated. There's things we cannot measure. We cannot measure what's going to be FDA approved next month, next year. We cannot measure the power of the person being involved in their care. But we know it's there, but it's hard to measure. We can't measure it as exactly as we can a PSA, et cetera. So I was doing shared decision-making before I even knew what it was. And so now I try to pay that forward to people and help them understand that you can do it, and some bullet points of how to do it. And so we're going to talk from that perspective today. One thing I want to share with everybody is that in our medical system today, we've all experienced the pressure and the strain on the doctors. I want to mention, because I didn't even know this till about a year ago, there is a physician shortage across almost every field in the United States. So, and you can Google physician burnout even. And I'm saying that because it helps patients to understand what's happening in the clinic and with our doctors. And maybe I would start my doctor's appointment now with a simple thank you, and then I would go from there. But these are real problems. If you understand the problems, you can be part of the solution, create the solution, and still work your appointment, which is what we did. So I wanted to give that, just lay that down. Dr. Sartor, any comments on any of that?
No, I enjoy good questions because it indicates you're thinking about the disease. And it's actually hard when I speak without a good feedback from the patient, because they don't quite know where they are. And, you know, patients come from all over the place. And I have janitors that I treat, and I have CEOs that I treat. And I have rich people, I have poor people. And everybody's concern's a little different. And if I don't hear about your concern, I'm never going to understand your concern. So being able to talk to your physician and ask questions is very helpful for you to get better care and to have your concerns addressed.
Thank you so much. Okay, so we're going to speak about nuclear medicine treatments, which is a follow-up to the talk about nuclear medicine imaging. So in prostate cancer, there's 2 treatments, nuclear medicine treatments, that are FDA approved in the United States for prostate cancer. Let me make sure my clicker works. Let's see. There we go. So in an effort to do plain language, I always use both brand name and generic name. Do you mind if I ask you, as a physician, sometimes patients get confused because physicians and researchers speak in generic terms and we read in brand name. So why do physicians do that?
Oh, you know, I think we're kind of trained to think about the chemical name, like radium-223, I refer to as radium-223 more so than Xofigo. I mean, Xofigo doesn't resonate with me very much, but radium-223, I know what that is.
Right. And is it a point also of not being seen as being branded, but just speaking to the chemical in case, let's say that one case scenario would be another company might pick up the same chemical. Something like that.
I mean, it could be. I mean, right now we have Pluvicto for PSMA 617, lutetium 177. That's a bit of a mouthful. So, you know, I mean, Pluvicto probably does have a pretty fair amount of use today because there's no competition for PSMA lutetium. It could face competition. I mean, there's a company called Curium that's running a trial called Eclipse, and that could be PSMA INT lutetium 177. We don't have that on yet. So, in part, you know, we speak out of convenience and a little bit of fluidity. But, you know, in general, I do kind of prefer the chemical name, assuming that it's doable.
Yes, okay. Well, I hope that explains for people because we get confused. So we'll use both names to help with any confusion. So in reference to Xofigo radium-223, if I'm a patient or caregiver and I'm trying to decide on Xofigo radium-223, and we had talked about this a little, in simple terms, this treatment will get paid for by Medicare if you're what we call on-label, which means the label, when a treatment gets approved, it gets FDA approved, then it gets FDA labeled. And that label tells you which patients basically insurance will pay for. So I laid out as best as I could what would be the patient that Medicare would pay for. So is this accurate? On hormone therapy or testosterone suppressed, PSA rising, or more cancer on imaging, which is called metastatic castrate-resistant prostate cancer, which is another mouthful. We have a lot of mouthfuls. Bone metastasis specifically, no known soft tissue metastasis.
Yeah, not quite accurate, but let's go ahead and throw it. I can,
Yeah, help me
I can
out
kind
with
of
that
comment.
then.
So
Yeah.
the original phase 3 trial, so the label is based on the trials that are run. And what we call the inclusion and exclusion criteria, who gets onto the trial, will determine the label when the FDA approves it, if they do. And this was designed for metastatic castrate-resistant prostate cancer patients with bone-dominant disease. It didn't be bone-exclusive disease, but we didn't want people with visceral metastasis because radium only goes to bone, so visceral would be something like lung or liver. So radium doesn't go to lung, doesn't go to liver, so why would you use radium to treat someone with lung or liver disease? The symptomatic was a little bit weird, and symptomatic caused a lot of trouble in the label because did that mean fatigue? Did it mean pain? Did it mean you're symptomatic in your head because you're thinking about it all the time? I mean, it's a very nebulous term. And that has kind of been dispensed with when it comes to radium. I mean, the symptomatic part is difficult to interpret, and so I kind of dispense with it.
Okay.
One thing, and this just for clarification and maybe interest, and when thinking about radium, because it's a bone-dominant osteoblastic disease, only works for osteoblastic. It doesn't work for osteolytic. She's probably looking at me and saying, why are you using that big
No, I got it.
osteo word? I guess that's the terminology we use. Lytic means destructive, blastic means forming, and the typical prostate cancer is blastic, meaning bone forming. And radium is taken up into the bone forming elements, but not the bone destructive elements. So we're looking for that bone dominant patient, castrate resistant, metastatic, and that becomes a reasonable candidate for radium so long as their soft tissue disease is not too predominant.
So visceral means, in simple terms, soft tissue metastasis?
No. Viscera refers to organ.
Okay.
So, I mean, you can have lymph nodes, which are not viscera.
Got it.
Viscera would be like lung and liver.
Bladder?
Bladder, it's kind of
Rare,
a weird one.
really
Well,
rare.
I mean, it's typically local invasive into the bladder, but
Okay.
it kind of depends on how bad it is.
Okay. And I want to reference this. I find that liver and lung get mentioned, liver metastasis and lung metastasis get mentioned together a lot, and they both start with an L, and sometimes we think they're similar, but
They're not.
thank you.
Yeah, they're not.
Elaborate, please.
Yeah, liver's bad, lung's not so bad. And one of the things interesting about prostate cancer, you can look at the location of the metastatic disease and have some idea about the prognosis. I call it the hierarchy of badness. Lymph nodes are pretty good, relatively speaking. Bone is not so good, and liver's bad. And so in that hierarchy of badness, I'm kind of calculating like where the patient's going to end up. And truth is, lungs are more like lymph nodes than they are liver.
Thank you
even
for
though
that.
even though they're both viscera.
I think that's really important information.
Yeah.
Really quick on osteoblastic, most prostate cancer metastasis, this is something you probably see on a regular bone scan.
Mm-hmm.
You could distinguish between the thing that looks like a bump in the bone as opposed to a dent in the bone. Is that
Yeah,
that fair?
pretty easy. On a bone scan, you're basically imaging what we call the hydroxyapatite, fancy chemical name for the bone stroma that forms from the blastic lesion. Bone scan hot, that means it's blastic. Bone scan negative, it's not.
Radium would be for blastic metastasis.
Radium is for blastic.
Thank you very much. Okay, next one, I just think it's helpful for patients to understand that there's only two different types of physicians that administer Xofigo or any nuclear medicine treatment. Nuclear medicine physician, oncologist like Dr. Al McGuile. Did I say your name right? yes, okay. And then a radiation oncologist. I'm not even sure people really understand that. Whereas your medical oncologist or your urologist may refer out to one of the two. Is that how you would say it?
Yeah, there's something called an authorized user, and the ability to administer a radioactive material is restricted to those who have special training. So somebody like Frankus in nuclear medicine is an authorized user. I am not. I don't have special
Because you're a
training.
medical oncologist.
I'm a medical oncologist.
Right.
And urologist is not. So your radiation doc, radiation oncologist, or nuclear medicine doc are the typical authorized users.
Okay, next slide. Question, I think patients do wonder about this. If I'm on one treatment, here we're talking about Xofigo, radium-223, are there situations where I might consider taking another treatment along with it? Not everything is contraindicated, but not everything clearly has been studied or goes together. So we talked about, so there's a trial, let's go to the second bullet point first. Zytiga or abiraterone did not do well in a trial. It would be contraindicated? What would be the right word?
You know, I have maybe a different perspective on it.
Thank you.
The Area 223 trial
Yes.
was an abiraterone plus or minus radium trial.
Yes.
That did not do well. Tons and tons of fractures, and the patient didn't do very well. It is not indicated to give those two together. Interestingly, however, the defect in that trial, which was a defect that was never corrected, is the bone health agents
Thank
were
you.
not co-administered.
Yes.
So bone health agents could be things like denosumab, things like Xgeva.
Right on the
because-
bottom,
Yeah,
yep.
there you go, denosumab,
Yep.
Xgeva, or zoledronic acid, Zometa, and those are the brand names and the generic names. So zoledronic acid, denosumab, same thing as Xgeva, Zometa, okay? So when you give the bone health agents in combination with radium and abiraterone, the truth is you dramatically decrease the fracture rate. The problem is it was never done in a prospective trial that way, and so consequently the abiraterone is not used. And if I draw a contradistinction to that, the PEACE-3 trial looked with enzalutamide combo, very interesting.
First
and-
bullet point.
And not necessarily well known. So the PEACE-3 trial started out disastrously. And the disaster was the fracture rate was through the roof with a combination of enzalutamide and radium. And I happen to be on what we call the data monitoring committee. Big trials have independent data monitoring committees looking over it, try to look out for the safety of the patient. And we noted this fracture rate very, very early. And the Data Monitoring Committee put out a strongly worded letter saying, you must give bone health agents if this trial is going to continue. And if you're not on a bone health agent, your physician must justify why not. So the default is you do it, and if you don't do it, you tell us why. Because of that, and we have before and after,
Yeah.
the fracture rate dropped dramatically. And the enzalutamide radium combo trial is positive for overall survival. It's complicated. It's presented at ESMO 2024. ESMO, the European Society of Medical Oncology meeting, big meeting. There are two big meetings. ASCO, American Society of Clinical Oncology, ESMO, European Society of Medical Oncology. Presented at ESMO 2024 by Silke Gillison, great investigator out of Switzerland. And Silke presented it very conservatively. The statisticians had some questions about the trial, and they wanted to have more data. That data is actually now accumulated, and they haven't analyzed it yet. We'll look forward to a new analysis on PEACE-3, never reported in the peer-reviewed literature, but it will be.
Okay.
And I think it'll likely get an FDA approval.
Very interesting. I think the bone protective agent, I think they call them BPAs, bone protective agents, so I try to use the same words. It helps patients.
But in fairness, some people call them bone health agents, some people bone protective agents. You know, so the nomenclature's not fixed.
Yep. But I think it's important that patients who are metastatic and on testosterone-suppressing drugs be asking their doctor, and this does get overlooked, I've seen it many times, for a DEXA scan, number one, which is easy, quick.
Ooh.
Help me out.
No,
No?
not true. Because see, here's No, and I'm not trying to be rude.
No, you're
I'm just
not
trying to
at
be
all.
corrective.
This is good.
No, because see, when you have bone metastatic disease, you got to be
Right.
very careful doing a DEXA scan.
Right.
Because the blastic lesions
Yep.
increase the bone density.
Yep, falsely.
So if you're, no, not falsely, it's a real increase, but
Okay.
it's not measuring your natural bone.
Okay.
So there's a distinction between the metastatic lesion and the rest of the bone.
Thank you.
When you're running a DEXA scan on somebody with a metastatic lesion, you got to be very careful not to assess the bone where metastases
Where-
are, because then you get fake. And I'm going to complicate it, but I'm going to simplify it.
Yeah.
There are two elements here. There's the bone that is not involved and the bone that is involved. For the bone that is not involved.
With metastasis.
With metastasis,
Right.
we worry about osteopenia, osteoporosis, fancy word meaning loss of the bone strength, which we can measure with the bone density. For that,
Right.
and this is, again, a little bit confusing, we use the second version of denosumab, one called Prolia, and we use the second version of zoledronic acid and only give it once a year. So for osteopenia, osteoporosis, we use one thing. For those at risk for pathologic fractures where there's bone metastasis, we use these two, which is denosumab at a different dose and zoledronic acid at a different dose. Now, to complicate things, but to be honest, the dosing is not well worked out. And there's a lot of interplay between giving too much and not enough, and we don't quite know.
So what should I ask my doctor? Okay, so if you don't have a they typically scan with a DEXA scan, the left hip and then the lumbar area, correct?
Some people do wrist as well, so but they're different
That's an
standards.
ultrasound, isn't it? Okay.
No,
all right.
no, their DEXA's on the wrist, wrist and hip and lumbar.
So if you're scanning an area of bone that does not have a bone metastasis, it may be a valid imaging.
Absolutely.
Okay. And, but what I find is missing is that anybody measures anything, the doctor in the clinic, to be fair.
Yeah, but
And
if you-
so the patient doesn't get the bone protective agent. This is the point I'm getting to. So
Yeah.
ask.
One
go
more,
ahead.
one more clarification.
Yes.
So the bone health agents for osteopenia, osteoporosis are being driven by the DEXA scan or bone mineral density. But if you have bone metastatic disease, it's a different category.
Then you can order Xgeva.
Then you can potentially order
Without a
Xgeva or
DEXA scan.
zoledronic acid.
Thank you.
However, this
Yes.
is an important point. The actual dose intensity is debatable.
Okay.
The FDA approval came out once monthly, and it's not clear that that's really the right dose.
Understood.
Okay.
That gives patients a good thing to research, a good thing to ask their doctor about.
Absolutely.
But still, don't avoid the discussion about bone protective agents, even if your doctor hasn't brought it up.
Absolutely.
The risk of fracture is real.
And if you're on radium, then you ought to be on a bone health agent.
Okay,
Period.
thank
Because
you.
that means you have bone meds.
Right,
Yeah.
right, okay. So then I brought up both Nubeqa, darolutamide, and Erleada, apalutamide, just because they haven't been studied in conjunction with Xofigo, radium-223.
Yep.
But I just wanted to make the point and then lay it out there. Who knows if they'll study it one day? I don't know. You said the Peace 3
No.
trial, yeah, is,
Took 10 years to run.
yeah, got it, okay. I want to remember that we're talking about things in the United States, but people on YouTube could be listening from Canada. But it's not only live right now, but it's going to be on the internet, and we don't know who's going to watch this. So we're speaking a lot to USA data, but there may be other people in other situations. Okay. So if I was receiving Xofigo, radium-223, I'm convinced that side effects are something that often get overlooked in the clinic or understated. So focusing on them is a big part of my shared decision-making effort. So I know that hydration is recommended. I actually wrote an article about that. It's on the last slide. What are some of the things that you can do to help a patient understand side effects better and prevent them or treat them?
No, they just communicate. Radium is one of the few agents ever where the adverse events within the placebo group, it's actually a placebo controlled trial.
But it was placebo plus standard of care.
Correct.
Thank you.
But it was placebo or radium, so nobody
Right.
knew if they were getting radium or not.
Right.
That the adverse events were actually less in the radium arm than they were in the placebo arm.
Right.
So you had less side effects if you received radium. Now, side effects is a broad term because this is related to the disease as well as the drug. But the truth is, radium was very well tolerated.
Okay. I want to keep going because I'll
I'm
talk
sorry.
too much and lose, no, it's me.
I
I'll
talk-
lose
No, I
time.
talk too much.
Thank you. By the way, if I'm learning as we go, that's exactly where I should be as an advocate. And as patients and caregivers, that's the place you want to be too. We're always learning, so, okay. So talking about self-care, family care, they'll go over this with you in the clinic, a technician or a nurse practitioner. But I do want to talk a little bit about getting your copies of your medical records, including your CBC, which has your hemoglobin, your hematocrit, white blood cells, platelets. Platelets can be difficult to recover, but there wasn't a big deal with radium, is that correct?
I think that maybe 10%.
Okay.
I forget the exact
Okay.
number. Wasn't too bad.
Blood counts weren't terrible, but still get your copies of your CBC
I
blood work?
think it's good to follow along.
Yeah.
Yeah.
Follow along. Anything, PSA response is,
Low, very low. With radium, it's probably in the 10% range.
yeah, the direct PSA drop, for example,
Yeah.
was difficult to measure, find, it was inconsistent.
No, it just didn't, it doesn't drop PSA.
It doesn't
Yeah,
drop PSA?
it just doesn't drop PSA.
Nobody got PSA drop?
Less than 10%.
Less than 10%,
No,
okay.
no, it's a rare event.
Yeah.
And radium, we could have a long talk on the mechanism of action of radium.
That's okay.
It's a stromal-based therapy. It's a radionuclide that binds to the stroma, not the cancer cell. The Pluvicto, or PSMA 617 lutetium, binds directly to the cancer cell, and there you get the PSA drop.
Interesting, okay. Thank you, I'm going to move on. We're going to move now to Pluvicto, lutetium-177. It's a much longer name than that, sorry I shortened it, because this is what most patients and advocates saw during the clinical trials early on was lutetium-177. Deciding on lutetium, like, again, which patients does Medicare pay for, what's on label? It's similar to Xofigo, but different. On hormone therapy or orchiectomy, but testosterone suppressed. Advancing disease measured by PSA rising or more cancer on imaging. Fair? So far, so good. So that's called metastatic CRPC or metastatic castrate-resistant prostate cancer. We used to call it hormone refractory. So patients and caregivers, if you're searching on this and you find that, you're tapping into an older term we used to use for almost the same thing. What's different about this is you need to have a PSMA PET scan that was positive.
Yeah.
Correct?
So what you need is a biomarker for the activity, and the biomarker for radium is a bone scan. You have to have a positive bone scan to be considered for radium. And for the Pluvicto, you need a PSMA PET scan that's positive. So there's a distinction in the scanning, and here we're targeting PSMA. This sort of gets back to the Theranostics that was raised earlier by Francis. So we've got to have a PSMA PET positive.
Thank you very much. Okay. This is the same as the Xofigo slide, which doctors give Pluvicto, lutetium-177. It's your nuclear medicine physician or oncologist and a radiation oncologist.
I'll mention one more thing about the indication.
Yes.
So we actually have a
Yes.
new indication that came out in March. And for the Pluvicto, initially, you had to have both chemotherapy with a taxane chemotherapy, such as docetaxel, and an ARPI, which is something like abiraterone and enzalutamide. In March, a new FDA approval came out in which you did not require prior chemotherapy.
Right.
So that's a new indication by the FDA.
And taxane is basically docetaxel or Taxotere. Those are the two names for the most part.
Yeah.
Although it could be,
It could also be cabazitaxel or Geftona.
right, okay. And it's pre-treatment with it, but it's a non-issue now because the label changed. Okay, thank you. So I'm going to move on from that one. And by the way, there's a couple of references here regarding side effects. To consider talking to your nurse practitioner or your PA about your side effects. Doctors, as we mentioned, are busy, sometimes over busy. And nurses and PAs, this is my own personal take. I'd be curious to hear what Dr. Sartor, his view on this. they have a tendency to be able to spend more time, or they listen, I don't want to say better, but they just have a knack for it. And so if you have a side effect, we tend to think of our doctor all the time, but if they're too busy, let's use our other medical professionals in the places where they're strong. And this is one for nurse practitioners and PAs. So during Pluvicto, again, can I ask my doctor about taking other treatments? Do we know if you should stop Xtandi? Do we know if you should stop Zytiga? What do we know?
So actually drawing on the Alsimca trial design, which is standard of care plus or minus, the same trial design was put in place for the Vision trial, which led to the first FDA approval. Standard of care plus or,
Pluvicto.
for
Yep.
Pluvicto, standard of care plus or minus Pluvicto.
Right.
And so people were on the abiraterons and insulamides and bone strengthening agents and the steroids and all that sort of stuff, exactly like they were in the radium. Now, the addition of something like abiraterone and enzalutamide is probably reasonable for those who are on the Pluvicto, but the only data that we have that's prospective looks at enzalutamide plus or minus lutetium from Lee's Emmett called the ENZA-P trial.
Okay.
And that trial showed that the combination of enzalutamide plus lutetium was better than enzalutamide alone.
Okay.
So different way of looking at it.
Yep. Okay. So it's an area we don't know. Perhaps you could talk to your doctor?
Absolutely.
Okay.
Great question. Some
Thank you.
people I do treat with a combination. Absolutely.
Okay. All right. So
And bone strengthening too.
so it's not contraindicated. It doesn't say anything on the label about stuff. Okay. What would be contraindicated is probably chemo along with Pluvicto? something
Yeah,
like
but
that,
we don't,
yeah.
we don't know if that's safe or
Yeah,
not.
yeah. Thank you. Our SPECT scan's important. We were just talking about that with Dr.
You know,
Allen
it's
as
a
well.
great question, and actually, I do kind of like a SPECT scan. The PET scan can serve the same utility, but then the PET scan is a separate test and more expensive. So the SPECT scan is you inject the lutetium, and then you can image later to see the lutetium and where it goes. And you can see if the volume of the disease is going up or going down, is it getting better, getting worse. I kind of like the SPECT scans, but I'm not adamant about getting them.
Okay, so I can ask my doctor about it.
Good question.
Thank you. Better questions get you better answers, so
Yep.
that's my tagline somewhere. Okay, during Pluvicto, self-care, family care, again, keep copies of your CBC, ask for them. It's your blood work. Nobody goes home with your cancer except for you. So, what about PSA response with Pluvicto as opposed to Xofigo?
Yeah, it's context dependent. In the Vision trial, the PSA response rate was, I'm trying to remember exactly, I think it's 43%. In the PSMA-4 trial, which is in the pre-taxane setting, is about 57%. And, you know, the rough rule of thumb for Pluvicto, and I think Frank has also said it when it works, it really works. About a third of the patients have like phenomenal responses. About a third of the patients, it doesn't work very well, and about a third are in the middle.
Okay.
But about a third of the patients are just like, oh my God, can you believe that?
Right, and the PSMA-4 trial was the trial where they studied Pluvicto on patients who had not had chemotherapy, not had Taxotere, docetaxel, so earlier in the disease. And the data from that was as good as or better than
Better.
better.
Yeah.
Better,
Now,
thank you.
survival is a little bit complicated, and I
Yeah.
probably don't want to go there, because we had a lot of crossover. The Vision did not have
Yeah.
a crossover.
Okay,
The earlier trial did, so, you know, like 57% of the patients who did not get the Pluvicto initially crossed over and did get it later. And I think the survival was screwed up, because, not screwed up, it was, it
Challenged.
mitigated the effect of evaluating the survival because of the crossover, because so many people received Pluvicto either way.
right. A crossover written into a clinical trial means that if you're on the arm that doesn't have the treatment and your disease advances, you're given the option to cross over into the group of the trial, not arm, people don't know what arm means, it's like this.
That's right.
The group of the trial,
Well-
where you can receive the treatment eventually.
Well, to state it another way, so everybody got randomized to Pluvicto, so 100% of those people got Pluvicto. the other arm was randomized to no Pluvicto, but the truth is 57% of those people still got Pluvicto.
Right,
So you're comparing 100% versus 57%.
got it.
And that's a little complicated.
And randomized just means that when you put people in the two different groups, it's random.
It
It's done
is.
randomly.
It is.
Thank you. That term's used a lot in clinical trials.
Yep.
During Pluvicto, again, can I do things to help prevent side effects? Do you tell your patients to hydrate?
Yeah, it's reasonable. I don't want anybody to be dehydrated, but hydration is reasonable, but it's not going to change that much. The dry mouth is probably the thing that's a little bit unique for the Pluvicto because you have salivary uptake.
Right.
And then we try to ameliorate those symptoms and things like xylitol and even chewing gum or candy. I mean, there are some things that we can do.
Right. And you said that using ice packs on your saliva glands to
Doesn't work.
prevent
Doesn't work.
has been shown to not work.
Shown not
Okay.
to work.
Okay. I think it's helpful to remember that the side effects do get worse as you go. They're cumulative for the most part.
You can often get fatigue. That can be problematic.
Do you ever have a patient ask you, patients are always weighing risk and benefit. Every treatment decision really should be made that way. If someone's got a great response, but they're really exhausted or having bad side effects, can they ask their doctor about stretching out the time between the next Pluvicto treatment, or?
Yes, and it's a little bit artistic now
Yeah.
because we don't really have the good data. You know, the good data was given at every 6 weeks, and alternatives to that schedule have not been explored.
Right.
Unless you have a phenomenal response. But I think there's always a lot of judgment that goes into the next treatment decision. And I'm not kind of an ex-cathedra guy where we say, okay, every 6 weeks we got to do it. That's my default, but it
Yeah.
doesn't mean we can't discuss it.
Yeah, and patients can ask.
Yeah.
Patients should be thinking about benefit, which is their response, side effects, which is, doctor doesn't know the side effects until you tell them that they might know the response. They don't know the side effects. So ask, speak up. I have seen patients who stopped a treatment that they were responding to because the side effects got so bad, and no one worked to either prevent them or help them with the side effects. And that's a shame because their cancer was responding to the treatment.
You know, risk-benefit is real, and we
Yeah.
have to evaluate not only the benefits of therapy, but the risk of therapy. And to your point, if the patient doesn't speak up, you know, how do I know if you're tired?
don't know.
You know, I mean, your fatigue, your dry mouth may be super bad, but if you don't tell me, I don't know.
Maybe affecting your appetite, which is important.
Absolutely.
Risk-benefit is exactly what's studied in the clinical trial and exactly how a treatment gets FDA approved. So if you're speaking to it in the appointment, you're speaking the right language. Here's a couple of articles. Full disclosure, I wrote the first two personally. And then a short article about risk of osteoporosis while in hormone therapy by another group, Dr. Mark Scholes out in California. How are we doing on time? Do we have any time for questions? We got a few minutes. Anybody have any questions? Thank you so much.
Thank you.
Anybody have questions? Is everybody tired? Come on, we need a little more coffee.
Again, Frank Leskis from Blue Earth Diagnostics. Dr. Sartor, you mentioned a little bit about the dose, or the time between doses and still being studied. What does the future look like for that algorithm? Are you basing it based on those that have responded, maybe extending that time or shortening the time for those that are not responders, or the variability in what will be a 6-dose regimen, an 8-dose regimen, a 4-dose? How are you thinking about that in the future?
For Pluvicto, you're.
For Pluvicto, yes.
Thank you.
Yeah, we're not thinking so much about stretching out the dose right now because we don't have a lot of data on that. I'm on Channel Louise Emmett from Sydney, Australia, who's been studying this probably more than anybody else. And I may have mentioned her name already. She's a fantastic investigator down in Australia. And she's been really studying pausing the dose among those people who have good responses. And I think it's 17, 18% of her patients just got 2 doses and then they paused and then be retreated when the PSA started to go up. And I think that's pretty reasonable for those people who have terrific responses. Do you need to get 6 in a row? And the answer is, you know, that's what the trial did, but it doesn't necessarily mean that's optimal. The other thing that Louise is doing is she's changing the way that some of the initial doses are administered, so crowding them together a little bit. And also it's being studied in England, so they're using the same dose of Pluvicto day 1, day 8, instead of day 1, day 43, which is 6 weeks. So they're like literally doubling up the dose. I did a trial with Scott Tagawa, great guy out of Cornell, and we gave 11.1 gigabecquerels on day 1 and day 15, so 22.2 gigabecquerels over 15 days. FDA approved is 7.4 every 6 weeks. So far, we haven't run into trouble, but how are people exploring it? We're looking at more intermittent dosing. We're looking at more front-loaded dosing. But right now, I'm happy to go intermittent, but in the trials, I need trials to be able to show that the more intensive dosing is safe.
Do we have any questions on YouTube? Sorry,
right here.
Go ahead, yeah.
Yeah, Jean-Luc Vanderheden with the Oncidium Foundation. You mentioned 1/3 of the patient do fantastic, 1/3 so-so, and 1/3 don't do very well on Pluvicto.
Yeah, it's kind of a rule of thirds.
Do we know what makes a fantastic response and what makes a terrible response?
Great question.
Yeah, great question. So I would like to add a simplified answer and tell you that what I'm about to say is not completely true. It's only partially true. So when we look at the scan, there are parameters on the scan, the PET scan, that can predict good response. What are those factors? Number one, imagine that the PSMA PET uptake has an SUV, standardized uptake value, extremely high, that it's 25. I look at your PET scan and everybody's got really bright disease. Let's imagine that that really bright disease is entirely within the lymph nodes. Remember my hierarchy of badness? This is the hierarchy of goodness. So when I see a patient with a super high SUV uptake in lymph node only disease, bingo, that patient's going to have a beautiful response. If I look at a patient who has a relatively low SUV, and I'll say SUV max of 6, and their disease is in the liver, guess what? They're not going to do very well. Imagine that I look at a patient and they have 159 bone lesions, and I look at another patient and they have 3. Guess which one is going to do better? So looking at what I call the SUV uptake, looking at the location of the disease, looking at the burden of disease, I have the capacity to make reasonable predictions. But you know what? I'm not always right. And there's some interesting factors that I don't understand that go into the equation as well. Great question. We're all learning, and we hope to get better at this.
So SUV is part of your PSMA PET scan report. This is the importance of reading your medical records, and it means standardized uptake value? Is that correct?
And higher is more uptake. And the thing that, is sometimes a little bit irritating, we don't always get that in the report. And it needs to be, as we evolve through the PET scans, we're looking, and I only gave you a partial answer, because we need more data to create something called an SUV mean, which is the typical uptake. And ideally, we'd also understand the heterogeneity of that uptake. And then we also have to understand about discordant lesions. So, I could talk about this for a long time, but it's a great question, and it's one that I'm personally engaged in trying to answer better.
Any other questions?
Yeah, so we have 3 more questions, so 3 minutes each, so we'll try to keep each to 3.
It'll be okay.
Well, she's till
At 4:10.
4:10, so I'm talking 4:10. Okay, so Mike Philbin, question, hereditary cancer. So my understanding is what, 10% of metastatic prostate cancer is family-related?
Are you talking about BRCA2?
Yeah, well, I'm leading into that. So which is typically BRCA2 mutations. Is there any special considerations?
I'm going to correct you. It's not typically BRCA2. BRCA2 is only about 38% of the hereditary cancers, with things like PALB2, CHEK2, BRCA1, and other parameters that need to be measured. So BRCA2 is only one of the many genetic factors.
Right, but either way, for hereditary type cancers, whether it's which one it is there any differences for men with hereditary cancers in terms of how Pluvicto works, or?
Yeah, so within the trial, there was an exclusion for those who were known BRCA2 metastases or BRCA2 genetic alterations, because we have an FDA-approved PARP inhibitor for those, things like olaparib, talazoparib, or the PARP inhibitors. And the FDA felt, and I would agree, that if you have these known alterations that are sensitive to a PARP inhibitor, go get your PARP inhibitor. So we don't have a lot of data on this, and it's a little bit of a mixed bag. There's some people who seem to think it's a little better, some a little worse, but we don't have a lot of experience with the unadulterated BRCA2 population. There's a lot more that we need to learn about genetics, and I'm actually studying that. That's part of my research.
Okay. Did we have a YouTube question?
We do. Online question. Can you go into further detail about precautions caregivers of patients on Pluvicto should take? How dangerous is the radiation exposure to caregivers?
Can you give information on how caregivers should protect themselves and home care, and how dangerous is the
Radiation exposure from Pluvicto to
Yeah,
caregivers.
It's not particularly dangerous, at least in my own way of thinking. You know, the way you manage the radiation risk is to keep distance, and it decays over time. There's a 7-day half-life. So during the first week, some distancing is probably appropriate, but, you know, probably having somebody sleep in a separate bed for a week is acceptable. And, you know, there are guidelines, some of these are by state, but social distancing, is it dangerous? I don't think so. At least, you know, we always prefer that less radiation is more better. You know, we don't want people to be unnecessarily exposed to radiation, but I think social distancing is probably the best thing. It's not a big risk.
I would like to ask a question about data regarding African American men and Black men in the VISION trial, the PSMA-4 trial. Were we able to recruit a large amount? What do we know about their response? And one reason that's
Poor.
interesting.
It was poor recruitment in African Americans. Remember, it was a trial that involved not only North America, but also many other locations, and the African Americans were a very small percentage, not able to say much. One thing we did discover from our genetics is there's an alteration called CDK12 mutation. CDK12 mutations do not respond well to Pluvicto, and African Americans have a higher percentage of CDK12 mutation.
Interesting, thank you.
That actually was a little bit of my follow-up question on the high responder, low responder, if there was any genetic test or something in the blood
Great
that
question.
could be helpful as a predictor, and what would you do if you had that information?
Yeah, no, great question, and an area of very active study. So I can tell you for the response rate that something called the circulating tumor fraction of the circulating tumor DNA is quite important. And this came out of a beautiful study that just came out in Nature Medicine by Alex Wyatt and colleagues. We published this in Journal of Nuclear Medicine. We found 3 alterations that seem to predict resistance. One of them was a CDK12 I just mentioned. Another was the CCNE1. It's also been associated with platinum resistance, and another called FGFR1. We're kind of at the infancy here, and the studies to date have not been definitive in my mind. The single best manuscript on this was just published by Alex Wyatt in Nature Medicine, and the degree of the circulating tumor DNA is an important parameter. Yeah.
We have about 5 minutes left. Is there maybe one more question? Look, Mike Crosby has a question.
Mike, I'm gonna follow up a little bit on his, because I think it's a very good question. This interplay between the genetics of the tumor and the scan and the response is an area of very active investigation. And there are elements that we now are beginning to understand about the individuals with a high circulating tumor DNA fraction or often have a lower PSMA PET uptake and a higher FDG PET uptake. You know, there are actually, 5 different types of PET scans that we can talk about. But the PSMA PET and the FDG PET give some alternative information. It's complex and we need to study it more. But anyway, provocative questions. I'm sorry, Mike.
Sorry, I didn't mean to.
No, but I
interrupt you.
I wanted to elaborate on that. It's a very good question. It's an area of active investigation.
So just real quick about investigations and trials. In your opinion today, what is the best source for patients to find appropriate trials?
For the Theranostics trial,
Yeah.
the ex-cancer site is the best that I've seen. I'm trying to remember the name of it. I think it's theranostictrials.com or .org.
Yeah.
Theranostic Trials, and it's part of the ex-cancer kind of suite of trials. That's the single best one. The NCI is also good, but it's a bit more complex. Talking to your physician is always good, but they often know about the trials where they are.
Right.
But, Google can get you moving.
Thank you.
Yeah.
Okay, I think we might have time for, maybe one more question, and then Mike, do you want to introduce our next speaker?
Sean Lucas got it.
Okay.
Just one more. So actually the use of FDG was usually not recommended for prostate cancer, but it looked like in the case that you're describing now with Pluvicto, we do need an FDG along with a PET scan, a PSMA scan?
Again, another very good question. So if you go to the Australian trials, they're typically using 2 PETs for the selection. The problem in America is even though you can get an FDG PET, and you might be able to certainly get a PSMA PET, if you try to get both, you're probably going to run into insurance troubles. In the design of the trials, we very specifically decided not to do 2 PET scans as a requirement because we were concerned about the reimbursement when we got to commercial activities would prevent patients from getting the 2 PET scans, and it's still true. So I can order 1 PET scan on you, and I might be able to order another one in 6 months, but if I try to do 2 PET scans and get them within a week, your insurance company is going to say, no way, we're not paying. So if I tell somebody I need 2 PET scans to evaluate you for Pluvicto, but I can only get 1 paid for, we've ended up in a conundrum. So again, in Australia, this is not a restriction. More PET scans, more better. Let's get an FDG PET. Let's get an Axman PET. Let's get a PSMA PET. Let's get a Covian PET. Let's get 4 scans, It'll be fun. But in the United States, it just doesn't work that way.
Thank you.
Okay, any others?
Just a quick thank you for one more question? No, 1 minute. Okay.
Oh, 1 minute.
Can we just thank Dr. Sartor for spending his time? Thank you.
Yeah, thank you very much, and it is a pleasure, and if anybody has more questions, obviously we've got some of the world's experts standing around in the room right now, so, as we have a break at our reception, please find them out, and there'll be others showing up as well.
All right. I'm going to need to run. But yeah, I'll tell you what, I'll hang out for about 6 minutes or so, then I've got to run for another meeting. But I'm happy to, go outside if I want to ask individual questions. Yeah, you're welcome. Thank you.
Okay, next, and the final talk of the day, but as Dr. Sartor and Dr. Amigel both said, this nuclear medicine is actually providing a lot of promise for patients right now, and it's changing weekly, I think, as results or trials are initiated. So it's important that we try to figure out access to all of these, and then access to drugs that are out of trial, like Pluvicto. So we're pleased to have a very special speaker that knows a little bit about this subject. Demetrius Thier is the Executive Director of Radioligand Therapy and Access and Reimbursement for Novartis. So here's the world's expert on trying to get access to the drug that we've all been talking about. And Demetrius, thank you for coming, and we're excited to hear your thoughts on how we can help patients get the right access.
Excellent. Well, thank you for having me. And Can you hear me? Is that good? And I'm going to share, obviously, about Pluvicto and Lutathera is also involved. But I think in general, these are applicable to most organizations. And so I would encourage you, as I've encouraged family members, as I've encouraged a very close relative of mine going through prostate cancer right now, all products, all organizations have programs like this. And so, but I'm going to speak specifically to Pluvicto and the Novartis programs. And I'll break it down in a little bit. So I'm going to break it down into three main areas. The first one being what we call access to medication. The second one being what we call the financial aspects of it for the patient. And then the third one, other support areas that typically come into play when there's questions or challenges navigating through certain things. So those are the three different buckets that I'm going to break things down to. All right, so what does it mean to have access to a medication? I think this is one that if you speak to your providers, they'll be able to share one insight. When you speak to certain individuals in pharma world or the industry world, they'll have another definition. But generally speaking, access means that, in this case, published policies that allow your insurance to cover that medication. And I'm going to talk in a minute about what does coverage mean specifically to you as an individual, and we'll talk a little more. But Pluvicto, when we look at coverage, is in the 80+%. Now, this is, again, published policies. Now, if I start to break that down, there's a large population of Medicare in this space in prostate, and many of you may fall into that. Some may fall into Medicaid, and some may fall into private insurance. For Medicare, and what we call fee-for-service, or what we mean by that is where a CMS pays an organization, a contractor, to cover or to administer benefits, that space is 100% covered, right? So that's one aspect. In the Medicare space, we like to say it's usually around 40 to 50% of that. The other part of it is what they call Med Advantage, and that is somewhere in the 90s, high 90s % coverage as well. And what do we mean by Med Advantage? Well, that's where a private insurer is contracted to administer someone's benefits. And you probably, if you're in the Medicare space, those are the predominant two aspects of how your insurance is going to be covered. If we look at Medicaid, Medicaid is fully covered as well, 100%. In the insurance space, that's where this policy element, and that's where published policy for private insurance, we have to look up that, we have to find that. So those are the three different aspects that I would say fall into this. And so you can see in this space, it's a fairly new product, and it's very well covered. And in prostate, that tends to be, and it's a good space to have insurance coverage. If we look at the next space, and this we talked a little bit about, so Novartis does what they call a copay coverage, which is very similar to most organizations. In our case, we do what we call a zero copay. Now, this is specific to commercial patients, or what we call private insurance. Now, there are benefits associated with those that have Medicare, those that have Medicaid, but that's a separate space, and that's what usually falls into what we call a foundation. Now, what's important about this is, and as we go through, I encourage everyone to utilize these pharmaceutical programs, because in this case, there are many different aspects that patients can benefit from. So if I go back to the first one, the access, Novartis does quite a bit of review to understand if it's covered, because there's different levels of coverage. Typically, you have to have what they call a prior auth. Now, this is something that most patients probably are not aware of. Your provider does a lot of the work behind the scenes, but that is a very important aspect that if you're signed up for programs, a lot of the pharmaceutical organizations will take care of that and look into that. There's also what we call, and that's usually the benefits verification. There's also what we call a benefits investigation. So if someone's interested and they're not sure yet if this is the right space or right product, they can also do a benefits investigation as well. So that's typically in the access. In this space, in the payer space, and the actual price, again, this goes into where copay is applicable. This is where Novartis is able to provide that coverage. And there are certain restrictions associated with it in every space, and every pharmaceutical company typically has that as part of it. The last piece, which I think is very unique, and you will see most pharmaceutical companies have some element of this, but I'm very proud of what Novartis can offer in this space. And this is a space, as you're navigating, and there were a lot of questions related to radiopharmaceutical, and there's a lot of questions that are really good questions, and not every physician, nurse has time to answer all these questions, or what I tend to find is a lot of patients, you have all these questions, you forget to ask them, and then you get home and how do I ask, and it's a difficult space. So Novartis has created a program where you can call in and ask all these questions, and it can be from what to expect, it can be all the way after, and it can be anything throughout therapy. And so the beauty of that is you have in a lot of cases, a former provider or a former healthcare individual that is able to answer these specific questions to your space. So again, I encourage, the main thing here I would say is I would encourage you, if you are going through any therapy, look into the pharmaceutical manufacturer and sign up for those programs. This is specific to Pluvicto, so if you are currently a patient, I would suggest signing up for this as well, because there are many different benefits. And I believe as well, and strongly in educating patients and patients taking on. I think actually we heard there's a lot of research that shows the more a patient is involved with their therapy and the more a patient is involved with their journey, the better they do. And this is one more aspect, I think, that I would encourage you to be involved with.
That's great. Super. Questions? And do you...
That is the number?
Yeah, right. There we go. That's what I was going to ask. And also, I'm going to ask for Frank, is that, are you the resource to talk to? Obviously, you're not going to come back down to Baton Rouge, but for local support groups that are seeing patients or patient support groups, do you have a rep that would come and talk about this topic at those support groups? Because it's a big issue in the community, is to try, they all want to get care, but we don't know how to get it paid for, or it's a challenge to a lot of guys sitting in the support groups. Do you have people that can come in and give a presentation on this? Even as simple as this.
So
I mean, we'll pass the phone number around, but so watch the lines light up.
You have our contact information. We have a couple different parties within our organization that can provide different levels of service. But I would say one of the easy ways is to start with this number. And it's online as well. And that's probably the best place to start. And those individuals will typically be able to direct you to where, but you have my contact information and we can work through that if that's needed.
And that also goes, I'm kind of looking out at the crowd at all of the industry, is we're finding that question coming up a lot, even more and more. And I think having people that we can bring into support groups to actually promote into support groups to give that access answer, right? I mean, who do they call? Why do they call them? How do you call them? That sort of thing would be nice, a nice additive, benefit to what you guys are offering.
Absolutely.
And so thanks very much, Demetrius. Yeah, appreciate it.
Thank you for inviting me.
No, it's our pleasure. If you hang around, you'll probably be here. You can get his card, and we'll have another chance to chat.
Excellent. Thank
Thanks.
you.
Yeah, thanks very much.
Very nice meeting you.
Okay, before we head off to the room for a little bit of a reception and relax after a long day, and thank you for sticking in for the whole day, you're going to get if you've participated, you're going to get a survey about the day and how it went. We really do take those serious. We read them all, and we try to better the program for next year. And we will take your comments. We'll be doing it again. If you're interested, we can reach out and recruit you for being ambassadors or being participants in SNMMI as well. If you're interested in a board position, we can talk about that as well. I want to thank all of our speakers. I think you probably recognize that those two physicians are two of the leading physicians in this field on the planet. I mean, their industry tries to get about 10 minutes of their time sometimes, and it's rare and far between. But they're good guys. They really care, and I think that those are the kind of physicians that we want to try to find. So I want to say thank you to everybody. That your participation here means a lot. And with that, I think we will close it up and move to the reception. Thank you very much.